Hi everyone, my name is Yannan Lin. I am a PhD student in the Medical Informatics group at UCLA, advised by Dr. Denise Everly, Professor of Radiology and Bioengineering, and Dr. William Shu, Associate Professor of Radiology and Bioengineering. I also work closely with Dr. Ashley Prosper, Assistant Professor of Radiology. Today, I would like to talk about an abstract I presented at last year's RSNA annual meeting and our next steps. In the abstract, we determined the association between changes in Lung-RADS scores and patient longitudinal adherence to Lung-RADS recommendations. In clinical practice, Lung-RADS 1 or 2 are considered negative screens requiring routine annual follow-up, whereas Lung-RADS score 3 or 4 are categorized as positive screens with shorter-term follow-up, additional imaging, or tissue sampling. In our analysis, patients were categorized into subgroups based on their Lung-RADS scores from the first 2 low-dose CT exams, which can be unchanged, meaning 2 consecutive negative screens or 2 consecutive positive screens. Upgraded, which means from negative to positive, and downgraded, which means from positive to negative. We found that patients with 2 consecutive negative screens or receiving a positive baseline screen followed by a negative screen may be at greater risk of not adhering to their next recommended annual screen. Therefore, interventions to improve patient adherence may benefit from considering changes in Lung-RADS scores between screens. What we have observed here at UCLA is that many of our lung cancer screening participants were lost to follow-up after their baseline screen. Patients may not be aware that to be effective, low-dose CT screening is not a one-time event, but a process that should occur annually for the duration of the individual's eligibility. More importantly, although associated with a lower risk of malignancy, a negative screening result does not mean that this individual does not have lung cancer. Although uncommon, it may be a false negative finding. It is also possible for nodule with a low risk appearance at one time point could become malignant in the future. As such, patients with a negative screen are encouraged to continue low-dose CT screening in 12 months by the Lung-RADS recommendations. The patient's referring physician also needs to understand these facts and take actions accordingly. Non-adherence to Lung-RADS recommendations was also observed among patients with positive screening results, but at a much lower rate than patients with negative screening results at our institution. Since our analysis was retrospective, patients who decided not to come back for screening were not contacted to record the reasons for non-adherence. Some of them may, in fact, be adherent because it was not possible for us to track patients who had permanently moved but continued lung cancer screening at outside institutions. Future studies are needed to understand these factors contributing to non-adherence among patients with both negative and positive screening results. Healthcare provider recommendations play an important role in influencing patient adherence to cancer screening recommendations. Based on our understanding of the non-adherent patients in our study, our lung cancer screening program has implemented interventions to address screening barriers at the physician level. Our team sends reminders to referring physicians to alert them when their patients' screenings are due. We will continue to collect more data for future additional analyses and will seek collaborations toward multi-center studies. In the future, our focus will be on assessing additional patient-level barriers to lung cancer screening, such as social determinants of health. We are also interested in validating physician-level and systemic barriers identified in other non-screening settings, such as in patients with incidentally detected nodules on diagnostic CT scans obtained for other purposes. Thank you for your time.